Assalamu alaikum. Good afternoon, everybody. Welcome back to the sessions in this afternoon. And we would like to thank again the organizing committee and the executive committee for their excellent organization for this conference. We have a very distinguished colleague who is going to give a very important lecture in this afternoon, which is going to deal with the tofacitinib real life data from local experience and international data. Prof. Hani Al-Muallim, he's, I think, known to all of us. He's a distinguished colleague who has done a lot of research in the field of rheumatology. Prof. Hani, he's a professor of Al-Zaidi, chair of research in rheumatic diseases, and he is a professor in the Faculty of Medicine in Al-Qura University. He's a consultant internist and rheumatologist, and as I mentioned, he has a vast experience in the field of rheumatology. So without further ado, I welcome my colleague Prof. Hani to give his talk.
Alhamdulillah, wassalatu wassalamu ala rasulillah. Thank you, Dr. Ziad, for this introduction. And sorry we are late by 5 minutes. Our audiovisual team were having a heavy lunch probably, so I hope you enjoyed your lunch, guys. My talk today, thanks for Pfizer for inviting me to present this session. So my objectives today is to review the importance of real-world data in clinical practice, to discuss mode of therapy and its impact on adherence. These really related topics, and I want to highlight the area of adherence and the mode of therapy and its importance in the day-to-day practice, to present the local experience from the RAS, Rheumatoid Arthritis Saudi database with tofacitinib, and compare it, not necessarily compare it, but actually address again the adherence point, which is a major topic in our day-to-day practice, patients' adherence. And I'd like to review also some real-world data and evidence related to the use of tofacitinib in day-to-day practice. So what is real-world data? So FDA definitions, it's patient health, anything related to patient health status and delivery of health care is considered real-world data. The analysis of these data that had many sources results in what we call real-world evidence. There are many studies that we can obtain, we can conduct to get real-world data, not necessarily randomized controlled trials, but randomized trials and surveys and retrospective and prospective case series. So this is classical for pointer. Anyway, so real-world data on the left-hand side. This is actually the randomized controlled trials where everything is controlled. It's called controlled, very strict research environment, very meticulous research methodology, very particular way of managing patients in order to get outcome, in order to have these drugs approved. And then you will get the real-world data. We'll have too many variables, too many patients kinds. It's not as much opened or restricted as the randomized controlled trials. This diagram represents the differences between randomized controlled trials and the importance of real-world data. And I really encourage all of us to report more and more from our local society, to know more about our diseases in our societies, and not only to rely on the data presented from other societies because we are different, not because we think we are on the top of the world. No, but I guess our genetic background is different, our social circumstances is different, our environment is different, so we need to study and this is the strategy that we are adopting in Al-Zaidi chair with the support of other collaborators, is to obtain local data, local experiences in order to build the future strategies for management of rheumatic diseases in our country. So randomized trial, obviously, high internal validity, unbiased methodology, very strict approaches, and there is blinding, but again may lack external validity because generalizability is not possible. You are excluding too many diseases once you are entering patients in your randomized controlled trials. This may not entirely represent the day-to-day practice. In real-world data sources like registries, the one that we are conducting, I hope all centers should have should participate in a registry, whether with us, Al-Zada Chair, or with Jamia Saudiya. We have to get registries in our societies. We have to study our diseases in our population, especially in Saudi Arabia. We are the largest community in the Gulf states. We are one of the unique countries in the entire world in terms of, do you know that? We are one unique country in the entire world that has really quick access to biologics, even better than European and North American countries. So we have a unique situation for research, for designs of studies, and I wish one day we can conduct our randomized control trials based on our own methodology with great researchers and great epidemiologists like Dr. Ziad, who can direct us and help us in obtaining and standardizing the practice of rheumatology based on our needs and our society and our environment. The real-world data, there is large sample size, a large size of databases. In comparison, we're very restricted population in based on the randomized control trials. But again, you may not have a control group in real-world data. This diagram represents an example of this real-world data that you can obtain. You can look at registries, you can look at extension trials of randomized control trials, which represent again, prospective trials and also the chart reviews. There is a huge source of data from our insurance companies. Until now, I'm not sure if we are approaching this kind of claims from insurance companies. We can get a huge amount of information directing our plans to manage our patients. So part of this real-world data, the concept of mode of therapy raises up. The WHO in 2003 stated clearly that increasing the effectiveness of adherence interventions may have far greater impact on the health of the population than any improvement in specific medical treatment. We are talking about biologics and target synthetic DMRs and new advances, but sometimes we do forget the patient's components of our day-to-day management. So adherence is something we really suffer from in our day-to-day practice. One of the things that really enhance adherence is to understand the preferred method of administration to patients. So patients tend to prefer certain ways, certain types of routes of administration of the drugs, and whether sub-Q, oral, IV, and this will affect adherence, ultimately will affect the outcome of the disease. So these kind of variables really, really important, and we should focus on these as clinicians instead of only focusing on the advances on the field. So in Germany, among 1,588 patients, the mode of therapy, oral administration was the most desired, and intravenous infusion was the least desired mode of therapy. At the most important levels were followed in this order. They don't want administration every 1 to 2 weeks. Imagine that. They don't want combination with methotrexate. This is a unique population in Germany, not necessarily applicable to our situation, but something to entertain. And the patients do not mind infection side effects. They do not mind allergic reactions to some drugs and other studies. They do not mind twice daily. So their major concern is controlling their pain, controlling their suffering from this disease in this study. Again, as you can see, so mode of therapy, as you can see on the second top there, the pointer doesn't work here, is the most significant thing that they have selected as preferred for them. Combination with methotrexate is not recommended in this population, this age group, and they do not mind, as I said, the allergic reaction and infection. In other study, this done in among 5 different countries, 100 patients with rheumatoid arthritis in North America and in South America. Again, the oral administration was the most preferred method, followed by self-injection. I'm saying this is a specified population, not necessarily applicable to ours. That's why we need to study our own population. This is just a review, just to tell you there are many variables that affect mode of therapy. Patient's age, patient's place of living, patient's level of education. I hear from colleagues, and I've noticed this, patients who are living far away from in rural areas, they prefer intravenous infusion instead of oral therapy. This doesn't go with the studies that I mentioned. They are saying there are so many variables that affect the choice of patients for their own selection of mode of therapy. So this we need to understand about our patients when we practice. Ethnicities plays a role, level of education plays a role. The number of medication patients taking per month plays a role in deciding what mode of therapy should be taken. But again, mode of administration or route of administration has the strongest influence on patients' reaction towards medication, and this is something that you have to be aware of. Just to give an example on how sometimes, not oral, I'm saying oral in these studies, but oral therapy may not be the choice preferred mostly by some patients, because if you switch from oral in patients who did not improve on methotrexate to sub-Q, adherence level has increased. And in this study, they doubled the time of low disease activity from 22% to 50%. Simply by just changing the mode of administration. So this doesn't go with the previous studies. I did present this just to show you how variable are the factors affecting the choice of our patients for the mode of therapy that they want to utilize. And this is area for research. That's why we are conducting this study in our patients here right now. We might present it next year. We want to study what the most preferred mode of therapy in our RA patients, Saudi population, and what are the factors that affect their choice of therapy. I'll present some local experience from Al-Zadi Chair of Research database. We published this already. We have 2 publications and 1 going, and we presented in last EULAR. In 2016, before the era of Janus kinase inhibitors in Saudi Arabia, the most prescribed drug in our population, around 400 patients, was etanercept, followed by adalimumab. This was in 2016. Within 2 years from the introduction of tofacitinib, look at the number. This was in 2018. 35 patients in comparison to 32 and 25. So within 2 years, tofacitinib overrided the prescription for anti-TNF alpha. And 2020, we did this analysis a few months ago. Most of our patients are right now still are getting tofacitinib. Sorry, how can I go back? Yeah, tofacitinib, and we are beginning to use baricitinib and upadacitinib. And we have excellent remission, and this is the most recent update. We published this also last year, but this is the most updated one, 539 patients in Faqih Hospital. We are having more centers right now from Jizan and from King Abdulaziz University, Prof. Suzanne, and inshallah King Abdullah in Jeddah. I wish also Al-Haras, Dr. Ziad, to join us. So real life scenario, these quick scenarios for you just to present how what kind of patients are getting tofacitinib. This patient is elderly, 84. For those who are reluctant to use biologics in elderly, I have 84-year-old who's been having rheumatoid for many years. She didn't respond well to biological therapies, so once we switched to tofacitinib, her disease activity is under control. And she's living between in and out of Saudi Arabia, and she's happy and a very happy lady with this mode of therapy. Another female patient, 44, diagnosed in 2011. She didn't respond to anti-TNF alpha, but she used also rituximab. We stopped rituximab and switched her to tofacitinib, and right now she's very well controlled on tofacitinib. So I'm presenting really complicated, long-standing rheumatoid arthritis cases where they did respond to tofacitinib. Another elderly, 60-year-old male patient, same scenarios, lack of response, and we didn't use biologics, but immediately we used tofacitinib and methotrexate, and she had excellent disease response. This girl, she's a dentist. She had very aggressive deforming arthritis. She didn't respond well to etanercept because of side effects and adalimumab. Right now, she's really, with her chronic deformity, her pain is under control. She did graduate from her dental college, and she's an intern now, and she's happy with the tofacitinib use. Okay, so from real-world data, we can create questions. We can create research questions like this question. Can you stop methotrexate? Can you stop methotrexate and keep tofacitinib as monotherapy once you have achieved low disease activity in some patients? So this was the question that the research question for oral shift study. I will not go into the details, but very unique design. Thanks for the AbbVie Symposium. They presented the most latest studies on all the drugs, including tofacitinib. But this study is unique. Why? Because they have evaluated patients on low disease activity after they have achieved with the tofacitinib and methotrexate. And then they did randomization to tofacitinib and methotrexate compared to tofacitinib alone with placebo. And the outcome measure was non-inferiority margin of 0.6. And this was achieved, as you can see in these slides here. The non-inferiority margin was not, sorry. Anyway, it was achieved. So tofacitinib monotherapy is not inferior to combination of tofacitinib and methotrexate in patients who have achieved low disease activity in the open label phase. This is an important question for us, important thing. For patients who do not want to continue on methotrexate, and if you want to decrease the amount of drugs that have been taken by medications and to improve adherence. The same theme that we are talking about it since in the beginning of the lecture. So that's 28 ESR, comparable findings. This is at the randomization, and then you can see that both outcomes are really comparable. No statistical differences between both of them. And this is the ESR response in double-blind phase, really comparable findings. Same thing with the remission rate. Okay, another question came up also from the real-world data that you are, or day-to-day practice, if the tofacitinib use increase the risk of malignancy. Many, two meta-analyses done, including clinical trials and extension studies, no significant increased risk of malignancies, not only for tofacitinib, but also for other biologics, compared to those treated with placebo or conventional synthetic DMARDs. So there is no signals for worrisome in these patients who are taking tofacitinib or other biologics. So is the infection risk the same in tofacitinib users compared to other biologics? There are so much variable findings in the literature. Dr. Nizar Bahabri presented a few things about the safety margins for most of these drugs, the risk of TB, and for other biologics. But in general, the incidence of infections was similar to that observed with other DMARDs. So you don't have any worrisome signals, unless I'll be mentioning in a minute. In this study, however, there are other studies that contradict this finding. In retrospective meta-analysis, the pooled data for RA trials indicated low risk of infection in tofacitinib-treated patients in patients treated with biologics DMARDs. Some studies showed no. The risk of infection is higher comparison to etanercept, for example. So it depends on what study you are reading or what study you are. But overall, there is no really big worrisome sign unless you are talking about varicella zoster. There is definitely higher risk in tofacitinib-treated patients, and I hope all of us are appreciating this. I had patients with zoster infection who developed, and sometimes they may not have the typical rash that you all see. You may have only a pain and one or two vesicles, so you have to have high index of suspicion for varicella zoster infection. Combination of JAK inhibitors and steroids. Steroids is actually number one. The highest risk for infection is with steroids, and we tend to forget that. So try to eliminate steroids from the management armamentarium for your patients with rheumatoid arthritis instead of keeping them on that for a long time without realizing the long-term side effects with steroids. It is therefore advisable to vaccinate. Dr. Nizar talked about the vaccination issue. Unfortunately, we don't have it here, so we cannot really widely use it in patients above the age of 50 before we can initiate biological therapy. This is and published in 2020, a very reassuring findings. The risk of DVT is not increasing in patients on tofacitinib and in rheumatoid arthritis, psoriasis, psoriatic arthritis. The risk only increases in those with higher risk for cardiovascular events and high risk for DVT. And this is pooled analysis for all patients. And you have to know that the tofacitinib dose of 10 milligram twice daily in ulcerative colitis trials, this is the dose that showed higher risk, even higher than the 10 milligram twice daily in RA. 10 milligram twice daily in RA is not approved. The approved doses in RA is 5 milligram twice daily or 11 milligram once daily. So still, you have to look for DVT risk factors, and you have If you have a patient with prior history of DVT or DVT risk factors very high, you may select other form of therapy instead of Janus kinase inhibitors. Overall, I'm just finishing my talk. There is a tremendous amount of real-world data available for tofacitinib, and I'm sure for other biologics and other JAK inhibitors, but just this is a kind of reassuring for us to be familiar with these new drugs and to have to step in and use them. It's approved in over 90 countries in the world. There are 7 phase 3 or 4 studies in RA, 2 longitudinal studies, a total of 7,061 patients used. There is a tremendous amount of experience of drug exposure over the years, patients' years exposure. More than 260,000 patients are using it for different indications, and we can sooner. There will be more and more indications approved by Saudi FDA or FDA for tofacitinib use. In summary, real-world data can be used to complement knowledge gained from the randomized controlled trials and to emphasize what have we learned in these trials in looking at its findings in the real-world data, if these are consistent findings or the risk of infection is continuing to be lower or higher. Route of administration had the strongest influence on patients' reaction towards medication. So we have to know what is the most suitable route of administration for our patients, and by one-to-one interaction with your patients, you need to understand what is the preferred method, and then you can go ahead and prescribe the right medication for your patient to ensure adherence. As I said, mode of administration is the strongest predictor of the adherence for your patients, so you need to know really what is your patient prefer to assure adherence, because adherence is more important than the most latest advances for your patient, for the most latest advances in rheumatology that we are learning by attending these conferences. Low disease remission and Xeljanz is comparable when given with or without conversion acidic DMARDs. So the oral shift trial is something added, so very important information to us that you can stop methotrexate if you want and keep patients on tofacitinib if he achieved low disease activity remission. This is very important information for us in day-to-day practice. The higher rates of hybrid zoster infection and the risk of infection is comparable with other biologics. It may be higher than etanercept. Real-world data has shown no difference in thromboembolic risk between Xeljanz and other biologics. And as I said, do not forget the risk factors for DVT and other cardiovascular diseases. And it is time to generate we have to continue generating data from our society. And I'm really a big advocate of our local research methodologies and local research that we have to do and more to know more about rheumatoid